Right. Now, good morning, everybody, and welcome to day two. Now, we continue with the opening statements. The first this morning is from Scottish COVID Bereaved, Ms. Mitchell KC. Thank you very much indeed, Ms. Mitchell.
Good morning, my lord. I'm Claire Mitchell, and along with Kevin McCaffrey and Kevin Henry Advocates, we're instructed on behalf of Amaranwar and Company in relation to the Scottish COVID Bereaved. The Scottish COVID Bereaved originally started out as part of a Facebook group, COVID Bereaved Families for Justice, which formed in 2020. Following a meeting with the First Minister, Nicola Sturgeon, in March 2021, it became clear that the Scottish Bereaved that they required to become an autonomous group within the COVID Bereaved Families for Justice. In the later half of 2022, they became a separate and independent group, namely the Scottish COVID Bereaved, in order that their voices could clearly and separately be heard. The Scottish COVID Bereaved are represented by the inquiries team at Amaranwar and Company, both in the Scottish inquiry and the UK inquiry. The group are a group of bereaved individuals with a common goal of not wanting their loved one death to have been in vain, and for lessons to be learned to stop others suffering the way that they have, and to ensure the next time a pandemic arrives, which it surely will, we are prepared. The members come from all over Scotland and from all walks of life. Although the group came about because of bereavement, within the group there are members dealing with other wider consequences of the pandemic, ranging from traumatised healthcare workers, teachers who had to buy their own disinfectant to keep classrooms safe and using their own money to feed pupils, to those dealing with long COVID and those dealing with the financial consequences of the pandemic. The group contains many individuals with expertise in a wide variety of fields, including medicine, governance, and science. Over the past day and continuing on today, we have been listening carefully to the other core participants who have set out their experiences. Sadly, many of those experiences are shared by this group. The inquiry will open to evidence of those affected by the pandemic, to give evidence as to how they and others were affected. They will raise their voices for those who tragically can no longer speak for themselves. The Scottish COVID Bereaved has already had the opportunity to give evidence at the UK inquiry, and they're in the process of giving statements to this inquiry, many of whom are keen to do so. And indeed, at the end of this week, we will hear from one of our members of Scottish COVID Bereaved. Each individual story provides a devastating vignette of the horror that they lived through and continue to live through, losing a loved one to a deadly pandemic. On August 24th, 2021, the Scottish Government announced that they were going to establish a public inquiry into the handling of COVID-19 pandemic in Scotland. This was followed by Deputy First Minister John Swinney on establishing of the inquiry, stating in Parliament that the bereaved would be placed very much at the heart of the inquiry. The Scottish COVID Bereaved expect that process to continue. They feel that sharing their experiences, both good and bad, will be of great help to the inquiry in assisting to establish what really happened during the pandemic and in its aftermath. Ultimately, despite the differing life experiences of the members, the Scottish COVID Bereaved are clear that what they expect from this inquiry is answers, accountability, and, where sincerely and appropriately made, apologies from those who failed Scotland. The bereaved want the legacy of this inquiry to be that when the next pandemic comes, the people of Scotland will not have to suffer in the same way that their members have suffered. The Scottish COVID Bereaved note the unfortunate history of the Scottish inquiry with the previous chair stepping down. Despite both inquiries being announced in 2021, Baroness Hallett is currently powering ahead with her UK inquiry. The chair, Lord Brailsford, said on appointment, "The public are rightly looking for answers, and no more so than the loved ones of nearly 16,000 people in Scotland who died during this pandemic. I am immensely aware of the enormous responsibility this places on me and the inquiry. I promise the families that along with the inquiry team, I will work independently to establish the facts and ensure the inquiry thoroughly examines the decisions taken through the pandemic." The Scottish COVID bereaved, quite rightly, expect the promises to them are kept. The inquiry is also embarking on a listening project, which the group are taking part in. It is vital for the chair to hear the voices of those directly impacted. Whilst it is understood that due to pressures of time, oral evidence will be limited, we ask, and no doubt the chair will, give the most careful consideration to the voices and experiences of those who have shared as part of the listening project. The UK inquiry has already concluded the module on pandemic planning, which has left the Scottish COVID bereaved in no doubt that a decade of austerity has left the NHS mortally wounded, the poor poorer, the sick sicker, and the UK in a more unequal place than a decade before. Brexit had put pandemic planning on hold, and despite important lessons being learned in pandemic planning exercises, the vast majority of the learning was left unimplemented. It is against that background that the Scottish inquiry opens to explore the provision of health and social care services, including end-of-life care and the use of do not attempt CPR notices. Ministers in England and Wales claim to have thrown a protective ring around vulnerable residents in care homes. But the policy not to isolate the people discharged from hospital to care homes in the first weeks of the pandemics of 2020 without testing was deemed irrational. But Scotland did exactly the same. By the end of March 2021, there had been 3,774 deaths in Scottish care homes. It matters not one bit to the bereaved if the care home deaths happened in London, Manchester or Glasgow. The policy of discharge of untested patients was ultimately a death sentence for the elderly. The Scottish COVID bereaved expects answers on the provisions of PPE in Scotland. The Scottish COVID bereaved expect to hear again from Jean Freeman, Scotland's former health minister, whether we failed our frontline workers who were crying out for PPE. Many frontline workers gave their lives trying to save ours, while our leaders were asking for us to clap those workers on our doorsteps every week. The group wished to know whether the Scottish Government properly considered the science and made appropriate decisions in light of that information, or whether they marched a few steps behind Boris Johnson into the deadly bedlam that he stands accused of his handling of the pandemic. The Scottish COVID bereaved note the scope of the inquiry, an intention as set out in the Memorandum of Understanding with the UK inquiry to minimise duplication between the inquiries. It is the experience of Scottish COVID bereaved that they and other groups have been front and centre of the UK inquiry, and we very much hope that experience is replicated by the Scottish inquiry. And of course we note that tomorrow this inquiry is not sitting due to the fact that there are other hearings going on elsewhere, and we are obliged to the Scottish inquiry in that regard. If the Scottish COVID bereaved and similar groups truly are to be front and centre of both inquiries, it is vital that the inquiries consider the timetable of hearings, as they indeed have done this week, to ensure where possible the hearings do not overlap. Certainty around inquiry dates and timeframes is key to ensuring that families are kept fully informed, and it reduces the anxiety about the inquiry process. The group have already raised this issue with the UK inquiry at its procedural hearings, and the Scottish COVID bereaved and their representatives note that they would require to hear evidence at both inquiries, and where it's necessary for hearings to take place at the same time, the members of the group and their representatives will require to catch up using recordings. And whilst it's great that technology allows this, hearing the evidence in real time is clearly always preferable. The Scottish inquiry will expect that key political individuals and their advisers, chief medical officers and scientific advisers, are expected to give evidence in this session of Module 2 at the UK inquiry. Their evidence is, of course, critical to Scotland in terms of the decisions they made UK-wide, and will very much feed into the interaction between Scotland, the Scottish inquiry, and the UK. There will be crossover evidence, and we very much intend for the relevant issues to be raised at the Scottish inquiry. The group asks that the Scottish inquiry follows the approach of the UK inquiry in giving core participants a substantive role in the preparation for inquiry hearings. Core participants are given copies of draft reports for comment, and draft evidence proposals are circulated with core participants who are asked to suggest lines of questioning and are able to put proposals for questioning and ask questions directly of witnesses, of course, where appropriate. The evidence led thus far at the UK inquiry already raises serious questions as to the Scottish Government's preparedness for a pandemic. The extent to which the machinery of UK government during the critical early stages of the pandemic allowed for the involvement of the Scottish Government, whether the available data reflected the 4 nations of the UK or just England, whether attendance at crucial meetings by Scottish Government ministers, civil servants and scientists were simply a charade, and whether or not COBRA, the Cabinet Office briefing room meetings, were actually, as has been described, a Potemkin village where the devolved administrations were operating under the false belief that they were playing a key role in the process, but real key decisions were actually being taken elsewhere. This, of course, makes it even more important to understand what decisions were being taken in Scotland, by who, and on the basis of what science and what data. In relation to the evidence, this inquiry will be aware that we raised the issue of WhatsApp message with the UK inquiry following the leaking of Matt Hancock's data to the Daily Telegraph. And subsequently, the Scottish inquiry was part of the UK inquiry judicial review in respect of those messages. The release of WhatsApp, social media and diaries and contemporaneous notes is critical in building a picture of the state of preparedness for a pandemic, the impact of those decisions, and to assist to examine the attitudes and conflicts that existed in liaison with Scotland's devolved administration. Whilst there has been success in the UK in inquiring and retrieving substantial qualities of material from the UK government and senior officials, the Scottish COVID Bereaved expect that process to be properly replicated by the Scottish inquiry for those witnesses relevant to Scotland. As the Scottish inquiry turns its attention to health and social care services, the Scottish COVID Bereaved turns their mind to those group members who were unable to be with their loved ones at the end of their lives. The thoughts of loved ones dying alone is something that continues to haunt many members of the Scottish COVID Bereaved. As time has gone by, members of Scottish COVID Bereaved have had more and more questions about how and why this was allowed to happen. A number of members of the group wonder whether the restrictions on visiting their loved ones was as a result of inadequate PPE supply. Many are aggrieved that it appears that guidance relating to visiting and attendance at end of life was not consistently applied, not only across health boards, but also within the same areas and even across different wards within the same hospital. Some members have reported that some of the guidance was simply nonsensical. They were told that they could not visit their terminally ill relatives in hospital, as they were advised that the hospital was not letting anyone who was not a patient, only later to be told by the same hospital that they would require to attend the hospital in person to collect the death certificate. The provision of end-of-life care and the subsequent bereavement has caused significant trauma to members of the Scottish COVID Bereaved. Many members feel a sense of anger and guilt about the standard of care that their loved one received before death. And there are some that feel that their loved one's death could have been prevented. Many feel ongoing guilt and anger that they were unable to advocate for their loved one when they most needed them. Members report having been advised that they were told by hospital staff that they had to choose between being present at their loved one's death or attending their funeral due to a clinician's misunderstanding guidance on isolation rules. The use of do not attempt cardiopulmonary resuscitation notices is a matter of grave concern to the Scottish COVID bereaved, and it's hoped that this inquiry can shed light on that. While the group focuses on the bereavement suffered by its members, it is not only end-of-life care that impacted upon the group. Members have concerns about clinical management of loved ones with pre-existing chronic conditions, or who were awaiting treatment for long-term conditions that are more prevalent among the elderly. Others have concerns about the treatment received by their loved ones before they progressed to end-of-life care. Answers are sought to questions in relation to nosocomial infections, hospital-acquired infections. There are those with experience of reduced access to formal care services for parents who were not residents in a care home, the treatment of care home residents, the historic underfunding the provision of social care services, and the consequences of this once the pandemic hit. We have already heard and seen in evidence during Module 2 of the UK COVID inquiry the insulting terms with which the then Prime Minister, Boris Johnson, described long COVID with the word bollocks, this is Gulf War syndrome stuff. And several months later in a WhatsApp message, do we really believe in long COVID? Why can't we hedge it more? I bet it is complete Gulf War syndrome stuff. It is essential to uncover what the impact of the UK government had on how such issues were handled in Scotland, but also whether such dismissive attitudes were replicated at Scottish Government level or by health professionals. We have already had the experience and the benefit of having world-leading experts appear at the UK inquiry, and it's therefore essential when experts are called by the Scottish inquiry, they are of the similar calibre, experience and excellence. According to the National Records of Scotland, as of the 9th of October 2023, there were 17,991 deaths in Scotland where COVID-19 was mentioned on the death certificate. Each of those deaths, and also the deaths where COVID was not mentioned, not only represents an individual tragedy, but has affected the friends, the family, the loved ones of each of those who died. No person, institution, no matter how powerful, whether it be in England, Scotland, Wales or Northern Ireland, can obstruct the search for truth. The Scottish COVID bereaved welcome the long-awaited start of the Chair's Scottish inquiry. We ask that all the witnesses who appear at the inquiry speak with absolute candour and brutal honesty, as without that honesty we will never learn the vital lessons to ensure that when the next pandemic comes, as it inevitably will, we are able to save thousands of lives and avoid the unnecessary suffering endured by so many in the pandemic. The Scottish COVID bereaved campaigned for this Scottish inquiry to be set up and to run parallel to that of the UK inquiry. They are entitled to expect a robust and fearless inquiry. The Scottish COVID bereaved welcome that their voices are being heard at both inquiries and that the bereaved must have trust in the process, which means that the Scottish inquiry must earn that trust and to recognise the central role active participants in this inquiry. Until they find the truth behind their loss, there's little hope of healing. And without that trust, it would inevitably impact on the Scottish COVID bereaved's perception of whether justice has been served. The Scottish COVID bereaved expect a public inquiry that listens to their voices and those of other core participants who have lost so much. In doing so, it will provide the foundations for an inquiry that delivers real change and accountability. That must be the legacy of the Scottish inquiry. I'm very much obliged.
Thank you very much, Ms Mitchell. Now, the Care Inspectorate, Mr. Macleod.
Good morning, Lord. Along with Emma Toner, Advocate, I represent the Care Inspectorate. The COVID-19 pandemic and the response to it took a heavy toll on Scotland and its people. In few places, perhaps nowhere, was that toll heavier than in one of the sectors regulated by the Care Inspectorate, namely care homes for our older people. In Scotland, there are approximately 800 care homes for older people, in which 44,500 or so staff are employed to care for around 30,500 people. When we think of care homes for our elderly, we think, of course, of those who reside there, many of whom lost their lives to COVID-19. But our minds also turn to their families, to their loss and their distress, and the lost opportunities during the pandemic to see and support their loved ones, and to provide and to receive the comfort and support that only family contact it brings. The Care Inspectorate wishes at this early stage to offer its sincere condolences to all of those who lost family members or friends to COVID-19, particularly in the care services it regulates, and across our society as a whole. As the regulator of services such as care homes for older people and care at home services, the Care Inspectorate also had an insight into the challenges faced by staff in those services during the pandemic. They had to continue to work in a professional way throughout COVID-19 outbreaks in their workplaces, and to do so despite their concerns for their own health. They had to deal with deaths of many people for whom they had cared and whom they held in great affection. They had to support grieving families. Some sadly lost their own lives. The Care Inspectorate also offers its condolences to their families and friends. While this inquiry may hear criticisms of the Scottish Government's response to the pandemic in relation to the care sector, and may hear evidence critical of some care services, their managers, or individual staff members, and while some of those criticisms may be found to be justified, the Care Inspectorate wishes to take this opportunity to recognise the overall contribution made by those working in the care sector in responding to the pandemic, whose efforts were arguably overlooked in a justifiable public outpouring of support for the NHS. My Lord, it is the principal role of the Care Inspectorate to regulate and inspect care services to ensure that they meet the required standards and to help, or in some situations, to compel them to improve if necessary. Across all of its work, it provides independent assurance and protection for people who experience care, their families and carers, and the wider public. In addition, the Inspectorate plays a significant role in supporting improvements in the quality of care in Scotland. The Care Inspectorate recognises the importance of this inquiry and welcomes very much the opportunity to participate in it. It is committed to assisting the inquiry in any way that it can, and has already provided it with all documents and information requested, and will continue to do so. Aspects of the Care Inspectorate's response to the pandemic which the inquiry may wish to consider include, firstly, whether it should have sought proactively to influence the thinking of the Scottish Government in relation to the discharge of individuals from hospitals to care homes in the early stages of the pandemic, although it had no role in overseeing or implementing that process. Secondly, whether its decisions to pause on-site inspection activity briefly, while aligned with those of equivalent regulators elsewhere in the UK and in Europe, were reasonable, proportionate and justified. And thirdly, whether its approach to the recommencement of inspections, earlier than its counterparts in the rest of the UK, using prioritised and risk-assessed on-site inspection, combined with the use of technology, was again reasonable, proportionate and justified. No doubt there will be other areas that the inquiry will wish to explore, such as the arrangements for care home visiting, where the Care Inspectorate will be able to assist the inquiry, or in respect of which the inquiry will wish to scrutinise the Care Inspectorate's approaches and responses. While the Care Inspectorate is hopeful that upon a close analysis, the inquiry will find that there was merit in its responses to the pandemic, it is not complacent. It takes this inquiry as an opportunity to hold a mirror to itself, to benefit from the insight that independent consideration of its actions brings, and to learn not only from the inquiry's formal findings and recommendations, but also from the evidence the inquiry hears as it proceeds, and from its own ongoing reflections on its practices in light of that evidence. Where changes or improvements are necessary, it will make those. Where changes or improvements to the services it regulates are necessary, it will encourage and, if necessary, enforce those. With that in mind, my Lord, the Care Inspectorate hopes that for all parties, this inquiry will bring new insights and recommendations which will leave Scotland as prepared as it can be for the future.
Mr. Macleod. Now, next we have the Central Scotland Care Homes, and I think it might be Mr. Gray. Am I correct? Yes. Thank you.
Good morning, my lord, ladies and gentlemen. I'd like to start by thanking your lordship for granting co-participant status to our group in this inquiry, for granting us leave to appear at this block of hearings, and for allowing us the opportunity to make this opening statement. I'm Alastair Gray, Solicitor Advocate, and I, along with my colleagues David Fitzpatrick, Sarah MacArthur and Sarah McNichol of rradar, represent a group of independent care home operators consisting of Oakminster Healthcare Limited, Thistle Healthcare Limited and Keene Premier Group Limited. They will collectively be referred to during this inquiry as Central Scotland Care Homes, or CSCH. Together, the members of CSCH operate 21 care homes throughout the Scottish Central Belt, with the majority concentrated in the Greater Glasgow area. They are small to medium-sized care home operators, with the maximum occupancy of their homes ranging from 24 to 106. They employ varying numbers of staff across their homes, with around 30 to 140 staff members assisting with the care of their residents at the smallest and largest homes respectively. CSCH's staff care for elderly residents who have a range of needs and care requirements. This opening statement is focused upon the impact hearings on the health and social care portfolio, but the members of CSCH wish to outline their ongoing commitment to assisting the inquiry generally by working with the inquiry team to provide invaluable evidence of their experiences during the pandemic. Our members were brought together by a common desire to have their voices heard, and the fact that, as small to medium-sized care home operators in the Central Belt, they operate in the same space and had similar experiences of the pandemic. They have a particular story to tell as they operate in the most densely populated areas in Scotland. The members of CSCH wish at the outset of this inquiry to extend their deepest condolences to the bereaved family members and friends of all of those that lost their lives during the pandemic through COVID or related factors. Every life lost was and is a tragedy. Their sympathies are also extended to those other individuals who have been significantly impacted by the effect of conditions associated with the virus, such as long COVID. It is hoped that this inquiry will serve as an appropriate legacy to their lives or their continued suffering, by ensuring that future generations are equipped with the plan and information required to avoid a repeat of the devastating impacts felt by the people of Scotland. The care which our members provide to vulnerable elderly residents is a service which all of us here today and across Scotland, our children and generations beyond them, may come to rely upon. The people deserve an inquiry which gets to the truth of how and why policy decisions were made by key stakeholders, including these decisions which affected the care sector and, importantly, vulnerable individuals such as care home residents. It has often been said, but is worthwhile repeating, that care sector staff were working under significant pressure in a fast-developing global pandemic and attempting to implement rapidly changing government guidance while caring for vulnerable residents. CSCH's staff at all levels worked under extreme strain in exceptional conditions. They had to continue their vitally important day-to-day care providing jobs, whilst also dealing with the significant toll of the pandemic, which meant, given the government's lockdown rules, taking on new responsibilities, such as being the only channel for communication between family members and vulnerable, sick, and tragically dying residents. The stories of the CSCH members are unique. They can provide insight into what was experienced on the ground in care home settings during the period that this inquiry has been established to consider. These stories cannot be told by the deceased, nor can they be told by families who had very limited access to their loved ones at the height of the pandemic. In essence, our members are able to provide the best evidence of the myriad impacts felt by those in this significantly impacted sector. And in saying that, to be absolutely clear, we are not intending to suggest for one moment that the evidence of the bereaved is unimportant. Quite the opposite. The evidence that will be given by the bereaved family members of care home residents will be among the most important, if not the most important evidence that will be heard in this block of hearings and in this inquiry generally. But as a matter of fact, family members of care home residents were not able to have normal access to their loved ones during the pandemic due to the restrictions that were in place. And that is where our members can assist, by providing evidence that fills the gaps for the bereaved and for this inquiry, by providing evidence of the full range of impacts observed in relation to care home staff members and residents in the times when nobody else was able to observe them. Our members are committed to providing that evidence in order to ensure, insofar as they possibly can, that no family member of a care home resident ever again has to experience the awful spectrum of emotions and impacts experienced by the bereaved during the pandemic, and that they continue to feel today. The members of CSCH report very challenging circumstances presented by the pandemic, not least because of the nature of the virus itself, but also due to difficulties with issues such as testing, the effects of hospital discharges, communication of guidance, and the expectations around implementing that guidance placed upon them by external agencies. At its conclusion, the inquiry must be able to report why key guidance and policy decisions were made and set out the lessons to be learned about those decision-making processes. Turning to guidance and outbreak management. The members of CSCH report a lack of consultation with the sector from decision-makers during the pandemic. The issued guidance changed frequently, and whilst that was to be expected as knowledge and understanding evolved, the messaging which came through was sometimes contradictory, and one member of the group advises changed twice in one day. The timing of guidance was often suboptimal, being issued late on a Friday or on a bank holiday, making dissemination of new guidance to staff more difficult. There were unrealistic expectations of the pace of implementation of advice and change. There was a rigid expectation that guidance would be implemented and implemented immediately. These attitudes led to a demoralising work environment for staff and service managers. The rapidly changing nature of the advice meant that there was worry amongst staff that they had been doing something wrong when following previous guidance. If there had been a collaborative approach with greater input from the sector, the CSCH members are confident that it would have led to better outcomes. Discharges from NHS hospitals to care homes were made at very short notice to help free up beds within the NHS. Many of the residents arrived without prior testing for COVID-19. At the beginning of the pandemic, there were issues around the declinature of treatment for care home residents when they became unwell and needed to go to hospital. Accident and emergency units would refuse to take residents, and care home staff were expected to deliver care out with their regular scope of practice. During this time, staff of all levels within CSCH reported as feeling helpless, knowing that medical care in hospital would not be given even when residents desperately needed it. Turning to external agencies. The CSCH members report that at the beginning of the pandemic, from March 2020 until around May or June that year, limited external agency visits to their care homes were carried out. This led to feelings of isolation for staff within the sector, who were trying their hardest to navigate through the toughest times. When the media reported cases of COVID in care homes, it prompted a very aggressive response by external agencies where, rather than support care homes, the members received several inspections and visits within a short space of time. These inspections were often unannounced, and the expectation was that all work was halted to enable participation in the inspections. There was no recognition of the extra responsibilities taken on by care home staff, such as becoming the only conduit of communication between residents and family members. Very little support or guidance was given, and many of the inspection reports did not highlight any positives and focused only on negative aspects. No context was taken into consideration, and little support was offered. An example of this is where there was an active COVID outbreak in one home and staff were required to isolate for 14 days. At this point in time, as part of a contingency plan, housekeeping colleagues helped to support residents who were unwell during staffing shortages rather than completing deep cleans. This was highlighted in one report as being negative. However, no support or advice was ever given as to how the situation could have been handled differently. When external agencies did visit care homes, it was evident that they were unaware of the practicalities of working within a care home. They had unrealistic expectations of advice implementation and changes. This left the service managers and staff feeling deflated and worthless. This contributed to what felt like a culture of blame and exacerbated the feeling of divide between external agencies and care homes at a time when everyone ought to have been working together. The members of CSCH were advised that although it was down to individual services to implement guidance and that it was only guidance, they were expected to follow it. Any inspections or health and social care partnership visits were judged using this guidance, thus removing the autonomy of services to make their own risk assessments based upon their unique knowledge, experience and judgment. The members of CSCH faced a significant increase in administrative duties during the pandemic. There was a requirement to report all confirmed and suspected COVID-19 cases to the Care Inspectorate, Public Health Scotland and local authorities. There was a major duplication in this workload. It is not known what the level of communication was between these and other agencies, but there appeared to be a lack of cohesion. In addition to that, all positive staff cases required to be notified to the Health and Safety Executive, and when a resident passed away due to COVID-19, reports and information required to be supplied to Police Scotland as part of Operation Coper. This was extremely time-consuming for staff and service managers who were trying to navigate COVID recovery plans while supporting hand-on care delivery to patients who were ill. When senior managers shared clinical observations with local GP teams and regulators in an attempt to collaborate and raise awareness of methods that had led to recovery of some residents, their professional opinions were disregarded. Our members felt that they had to advocate for their patients to be given a chance of survival and push external medical staff to help support this. This state of affairs made them feel utterly helpless, anxious, and exasperated, as it was contrary to everything that they believed in and had been trained to do. Turning to personal protective equipment, PPE. At the outset of the pandemic, our members felt that there was a lack of clear instruction with regard to PPE, including the use of face masks. Instructing staff, visitors and service users on what PPE to use and how to use it was frustrating and demoralising for staff who complained of feeling undermined and distressed. One member reported that they had no significant supply issues with PPE. However, obtaining top-ups initially at support hubs was difficult. Turning to hospital discharges to care homes. It is well known that in the early stages of the pandemic, decisions were made to discharge patients from NHS hospital settings to free space for acute COVID-19 admissions. Between 1st March 2020 and 20th April 2020, clinical advice was that a COVID-19 test was not required prior to discharge of asymptomatic patients. CSCH feel that many of these decisions led to outbreaks in their homes and would ask the Chair to carefully analyse the evidence in this regard. CSCH is aware of research from Public Health Scotland published on 28th October 2020 and similar publications since that date, which indicate that hospital discharges to care homes were a factor, but not a significant factor in leading to outbreaks. According to the Public Health Scotland report, the most significant factor leading to outbreak was the size of a care home in terms of its number of residents. It ought to be determined, as far as possible, whether the decisions to discharge patients from hospital settings to care homes did in fact lead to greater incidence of outbreaks. If it is ultimately concluded that size of care home was the main driver of outbreak incidence, CSCH wants to know why that was the case. If indeed that is found by this inquiry to be correct, it would suggest that a risk-based approach should be taken to management of future pandemics so that resources and support are appropriately concentrated in larger care homes where they would seem to be needed most. Turning to do not attempt cardiopulmonary resuscitation, DNA CPR requests. The CSCH group wished to highlight their concerns about the use of DNA CPR requests from healthcare professionals, where it was not always apparent that the appropriate consultations had taken place. To be clear, where appropriate, such requests were declined by the members of CSCH. Similarly, some advanced care plans prepared between families and residents, setting out the intentions for care towards the ends of life, were disregarded by hospital consultants. The assumption, in the main, was that COVID was the likely diagnosis, and this limited treatment and intervention. Again, the impacts of those decisions on residents, care home staff, and family members were profound and must be examined. Turning to the human rights-based approach, and in particular the right to life, the inquiry is required to take a human rights-based approach to its findings in fact and recommendations. At the preliminary hearing in August this year, Your Lordship reaffirmed your intention to do that from the beginning of proceedings. As part of this approach, the right to life will be in sharp focus during this inquiry, and in that regard our members would simply wish to remind the inquiry that the right to life is universal, applies equally to all, and does not diminish with age. Turning to cooperation with the inquiry. As the inquiry progresses, the members of CSCH intend to cooperate fully with the inquiry team. It is hoped that in line with the spirit of cooperation, the inquiry team will commit to making disclosure and communicating important updates in a timely manner, as expressed previously by Your Lordship at the preliminary hearing and in the published protocols for the inquiry. And I do recognise in saying that, my Lord, that since this statement was lodged on 16th October 2023, there have been several tranches of disclosure made via the online disclosure system, which I'm pleased to say is up and running and working well. In that regard, I do wish to express my gratitude and our group members' gratitude to Your Lordship and all of the members of the inquiry team for the enormous amount of work that has gone into getting us to this point. In conclusion, the members of CSCH look forward to assisting the inquiry in fulfilling its terms of reference in every way that they can, in the hope that recommendations will be made that have a genuine and positive impact on future generations and serve as an appropriate legacy to all those that tragically lost their lives or continue to suffer immensely as a result of the COVID-19 pandemic. Thank you, my Lord.
Thank you very much, Mr. Gray. Now, the next co-participant is a group made up of bereaved relatives, former care home staff and community response team. Ms. Macleod.
Thank you, my Lord. I'm Shelagh McCall, and with Grant Markey Advocate, I represent the bereaved relatives group Skye. We're instructed by PBW Law Solicitors. The bereaved relatives group Skye welcomes the start of this public inquiry. This group is made up of people whose relatives died in care homes, as well as care workers who bore witness to the conditions in those homes. Their experiences span 5 different health boards, including Scotland's island communities. The members of this group welcome the Chair's decision to hear first from those directly impacted by the pandemic in the health and social care sector. Their thoughts today are with their loved ones. While everyone's situation is individual and their grief personal, the evidence in these hearings will reveal a commonality of experience among the bereaved. Care home residents and their families were let down. They were let down by the lack of planning and preparedness at a national and local level for dealing with the pandemic. They were let down by decisions made by government. They were let down by failures in the inspection regime. They were let down by private care providers who prioritise profit and reputation over their responsibilities to care for residents, to protect them and to tell the truth. As well as revealing the suffering of individuals and their families, we anticipate that the evidence in these hearings will point to a systemic failure of the model for the delivery of care in Scotland, for its regulation and inspection. We recognise that those concerns are for later hearings, but as you listen to the witnesses describe their experiences, we urge you to be thinking of the questions that you should later put to those who made the decisions and those who implemented them. In due course, this group will be asking you to make recommendations that will ensure that the elderly and vulnerable are properly cared for and that what happened during COVID-19 cannot happen again. The bereaved want to know how it was and why it was that the virus was able to enter care homes when they were in lockdown ahead of the rest of society, and how the virus was then able to spread like wildfire within the homes. The inquiry will hear evidence that people were transferred into care homes from hospitals without testing. This happened at a national level with no obvious consideration given to local capacity or the best interests of patients and residents. It was at a time when it appears no Scottish hospital had reached a level of capacity that might have signalled an imminent critical incident necessitating such a step. The inquiry will hear evidence of staff travelling between care homes and to different parts of the country, including from England to Skye, with concerns that rules on self-isolation were not then followed. There will be evidence that care homes were entirely unprepared for a pandemic, and that once it began, staff were given little or no guidance and training on what to do. There were deficiencies in infection control, basic cleaning and hygiene. In one home, the alcohol-based cleaning products were locked in a cupboard to which staff were not permitted access by management. Instead, they cleaned using air freshener. There will be evidence of a lack of PPE or staff not using it consistently and properly. There were lax or no cross-contamination measures in place to prevent staff spreading the virus among residents. Staff were witnessed attending work while displaying symptoms. Once there was a COVID-19 outbreak in a care home, bereaved relatives were faced with a total lack of transparency about what was happening. Some learned of an outbreak from Facebook rather than from care home management or staff. There was no proper testing regime within the care homes. When direct questions were asked about whether someone had tested positive, relatives were lied to. The situation was only exacerbated by the decision of government that there should be a blanket ban on face-to-face visits with those in care homes. It's a natural human response to be as close as possible to a loved one in the final phase of their life. This was denied to care home residents and their relatives. While there is a recognition, of course, that measures to mitigate the spread of the virus and the risk of infection had to be implemented, bereaved relatives want to know why staff members were permitted to travel between their home and place of work, use public transport, spend time with their own families, all without taking protective measures, and yet still work closely with the vulnerable and elderly in care homes. Having listened to the witnesses' accounts, the inquiry should be prepared to ask the decision makers why alternatives were not considered, or if they were, why were they not approved? Why could families not nominate one relative to bubble with the resident to allow face-to-face contact to continue? Why did no one consider the cultural impact of denying the island communities their tradition of collective caring? The inquiry will hear that when relatives tried to contact their loved ones by video conference or telephone, their efforts were thwarted. Excuses were given about malfunctioning iPads, problems with the Wi-Fi network. The excuses kept changing. In some instances, management told staff not to share with the outside world what was going on in a home. Some staff formed the view that management cared more about their reputation in the community and the protection of their business than they did about the residents, their families, and the care workers who do the job not for the money, but because their heart is in it. Some staff went behind management's back, risking their jobs to keep families informed. Families' calls went unanswered over days and sometimes weeks. On some occasions when contact was made, families were treated with disdain as if they were an inconvenience. Families were told their loved one was fine, only to get a sudden, hurried phone call that they were dying. Many families witnessed remotely a significant deterioration of their loved one's physical and mental health in lockdown that was nothing to do with COVID-19. Some suspected their loved one was suffering from neglect, dehydration, and starvation. Questions were asked and relatives were fobbed off. The blanket ban on visits meant that care plans could not be checked. The inquiry will hear that when records were requested after a loved one's death, relatives found that the records were missing or incomplete. When relatives did manage to make contact over video with their loved one and witness for themselves the deterioration in their condition, there is evidence that at times their wishes about medical treatment were ignored or overridden. The reality for bereaved relatives is that some did not see their loved ones face to face again after the lockdown began. The right to visit during the last moments of life was not always granted, and if it was restricted to one family member. Some residents died alone. Care home staff witnessed many excess deaths. They held people's hands as they died. That trauma will never leave some of them. After death, some relatives were not given all their loved ones' belongings back. They suspect they were burned in spite of having been quarantined. After death, some relatives were so concerned about what had occurred that they reported the death to the police. They want to know how it got to that stage. The inquiry has promised to take a human rights-based approach, and hearing first from those impacted by the pandemic is a recognition of that approach in action, and that is welcomed. But a meaningful human rights-based approach goes far beyond that. The inquiry must investigate whether the right to life under Article 2 was respected and protected. We anticipate the inquiry will hear that people were pressured to agree to do not resuscitate notices, that people were not resuscitated even though no such notice was in place, that residents may have been neglected and left to starve, that families are not sure they were told the truth about their relative's cause of death, that the usual process for certification of deaths was departed from. The inquiry must investigate potential violations of Article 3, the prohibition on torture, inhuman and degrading treatment. Relatives will speak of their loved ones lacking food, water and hygiene, that there was inadequate, inappropriate, absent or delayed medical attention, that welfare attorneys' views were not listened to when it came to medical treatment, that there was inadequate staffing to provide proper care, resulting in residents suffering unnecessarily. We urge the inquiry to consider whether, in light of people's lived experience, the inspection and regulatory regimes were fit for purpose to prevent or remedy these harms. And the inquiry must also consider the impact of the restrictions that were put in place in care homes on the rights of residents and their loved ones to a family life under Article 8. We expect the evidence will demonstrate that no proper efforts were made towards maintaining relationships and that people's health declined as a result. When you come to hear from the decision makers and those who implemented the decisions and the restrictions, we want you to ask, did those people take a human rights-based approach? Did they consider that the result of their decisions and the restrictions that followed would be the situations that the inquiry is going to hear about in this first tranche of hearings? Fundamental to a human rights-based approach are accountability and a guarantee of non-repetition. Most of all, what this group wants the inquiry to ensure is that no family member, no care home resident, and no care worker in the future has to go through what they and their loved ones suffered during COVID-19. I'm obliged, Lord.
Ms Macleod. Right, now we're again ahead of schedule, but I think we'll take the break now, which is when it's scheduled. But could I ask you, please, it's now 10:55, so could you be back, please, at 11:15? Thank you. Right, now, next we have Independent Care Homes Scotland. Mr. McKie, thank you.
Yes, good morning. Morning, everybody. Good morning, my lord. Thank you very much. And I'd like to echo the thanks of some of my colleagues for allowing us core participant status and also for enabling us to make this submission today. My name is David McKie. I am with a firm called Levy & McRae, and my team working with me in this are Duncan Hamilton KC and at Levy & McRae, Stacey Fox, who's with me this morning, Raymond Gribben and Olivia Robertson. I represent a group called Independent Care Homes Scotland, or ICHS as I shall refer to them. They're a distinct group comprising 11 independent care home operators within Scotland. ICHS was set up to form a distinct voice for the independent care home sector and to provide evidence and submissions to this inquiry. Two statistics best explain why ICHS can assist the inquiry. First, about a third of all deaths registered as due to COVID-19 were from within care homes. Secondly, about 3/4 of care homes looking after elderly residents in Scotland are operated by independent providers. Listening to the independent care sector is accordingly a central part of understanding the COVID tragedy. Our focus is to put that essential experience and evidence before the Chair and indeed before the public. First of all, ICHS wish to express their profound and sincere sympathy to the families of those who died or otherwise affected by the COVID-19 pandemic. The members of ICHS were responsible for both staff and residents during the pandemic. Those staff were the primary point of contact for families of those in care. The passage of time cannot be allowed to obscure or to diminish the trauma and the tragedy of what occurred. This inquiry rightly has at its core the family members and friends who lost loved ones due to the pandemic. ICHS members were at the front line and dealt with many elderly residents who fell ill and, in many cases, tragically lost their lives. That burden was an extraordinary one and, at times, intolerable for staff to carry. This inquiry will look at processes, structures and decision-making. It's right to do so. But none of that can ever be allowed to distract the inquiry from the human aspect of this tragedy. That sense of hurt, grief and confusion which defined the experience many had in trying to understand and accept the inability to visit sick and dying relatives was real. It remains real for most. If this inquiry cannot get to the heart of why those making decisions and implementing national policy made the choices they did, it will have failed. Families and friends who have become an essential part of daily life in many care homes were barred from entry due to government restrictions. Those people were not able to say goodbye to relatives in their last hours or to comfort them and maintain essential human contact with those they loved. ICHS's role in this inquiry will be to give evidence, make submissions and seek both clarity and accountability. That starts in these first impact hearings by listening to the voices of those families and residents. It will then be about explaining, as well as possible, what decisions were being taken and which agencies and authorities were driving those policies. It will be about shining a light on areas of confusion throughout the pandemic response and ensuring that the public have access to the truth of what was happening. It will also be about making sure, as we look to the future, that there is no misunderstanding about the relationship between those making the laws and regulations and those charged with the responsibility for implementing on the ground. ICHS members approach this inquiry with humility and with an openness to learn. What this inquiry should insist upon is that those in power and the key decision makers at the time do so also. By way of background to those who are unaware, ICHS employ thousands of staff. Those are the people in care homes looking after residents day and night. Accordingly, the group had many staff and residents directly and indirectly affected by the pandemic, both in terms of their own physical and mental health and in their care and interactions with residents and their own families. The pandemic was very tough for most, but for those staff, it was at times a burden almost too great to bear. The statements and testimonies of some of those staff will be submitted and we hope will be made public. During the pandemic, care homes endeavoured to adhere to ever-changing guidance from central and local government and regulatory bodies. ICHS intend to provide evidence on how such changes affected key decision-making and, at this impact stage, in relation to how that landscape profoundly affected staff both on the ground and at managerial levels. It will also consider carefully and respond to any evidence disclosed by the inquiry to assist the inquiry reach conclusions or make recommendations for the future. ICHS is committed to being a constructive part of ensuring that the recommendations for change are practical, informed by reality, and will deliver for the public the greatest benefit. That means ensuring that a vibrant, independent care sector with decades of experience and daily responsibility for residents is at the heart of policy formation, not simply a passive recipient. ICHS is well placed to assist this inquiry. It collectively operates 156 care homes around Scotland. The members of the ICHS employ in the region of 13,000 staff within the health and social care industry. They are here not just to ensure a voice for the independent sector, but to represent staff, families and residents based on a vast collective pool of expertise and experience. One of the key aims of the inquiry is to investigate the strategic elements of the handling of the pandemic. That is expressed in the remit as being, quotes, in care and nursing homes, the transfer of residents to or from homes, treatment and care of residents, restrictions on visiting, infection prevention and control, and inspections. All of the investigations into the key strategic elements had a direct impact on employees within the ICHS group who provided frontline care for the most vulnerable members of society. They were placed in a position of increased risk of infection. Care home employees required to adapt to the ever-changing circumstances and were expected to implement novel changes required by amendments to guidance from both government at all levels and regulatory bodies. They were expected to do so instantly and constantly. They required to care for elderly and vulnerable patients, many of whom had cognitive difficulties and who did not necessarily understand what was happening. It fell on the shoulders of those people to deliver the impossibly difficult news to family members and friends who could not visit. As a consequence, the need for external communication with families was massively increased. Families unable to visit had a legitimate and desperate need for constant information about their loved one. Ensuring continuing lines of communication amid a global pandemic was exceptionally tough. Beyond that, and on a daily basis, the care had to continue. This was a pandemic which hit the elderly and infirm the most significantly. This included situations where, if infected, COVID often led to a rapid deterioration and, in many cases, death. Employees were deeply scarred not just by the number of deaths, but by the isolated nature of those last hours for too many. Nothing this inquiry can do will remove those memories and fully heal those scars. We anticipate that evidence will be led during the inquiry, both in written and, in some cases, oral form from employees of ICHS members. It's likely that witnesses of ICHS can provide vital insight which will assist the impact hearings, including the following areas of scrutiny. 1. The distinction between the private and public sector. ICH witnesses can address the key differences in the private and public sector which arose during the pandemic. There were a variety of guidelines not only across health boards but across local authorities and from central government which appear to have led to diverse approaches between the public and private sectors. It was felt by some of our members that priority appears to have been provided to the public sector, which was at times detrimental to the private sector and their ongoing operations during the evolving circumstances. One such example was the use of NHS terminology and guidance. It was often lengthy and confusing, but this confusion was added to by the use of acronyms or lingo, which was not used by private care home operators. Another example is the introduction of weekly testing of care home staff in the independent sector, which wasn't required by those operating in the NHS. It's hoped that the evidence which care home witnesses provide under this topic can identify lessons to be learned by the health and social care sector moving forward. 2, the impact of the government's guidance, central government. ICHS members have profound concerns across a range of the decisions made by government. Those we understand will be explored in later hearings, but they are made this submission because of the significant impact they had on residents, staff and families. These issues include 1, whether care homes should have been closed to visitors earlier than March 2020. 2, the delay in the introduction of weekly testing for all Scottish care home staff. 3, a 6-day delay in April 2020 between England stopping NHS hospital discharges without testing and Scotland also doing so. The decisions of Scottish Government and specifically the failure to lift visiting restrictions in the summer of 2020. Attempts by the Scottish Government to shift responsibility onto the independent care sector. Delays between government announcements and policy implementation and their impact on employees within the sector. Timing of updates. Key witnesses will be able to explore the direct impact on the handling of frequently changing government guidance. That is not simply in relation to the content of that guidance, but also on matters of practical implementation. Witnesses have identified key issues in the timing of the government guidance which had a direct impact on their individual work, their colleagues' work, on their residents and, as a consequence, on families. For example, one factor which hindered the sector was the announcements routinely being made on a Friday evening. Administrative staff members who were required in order to implement the guidance and who do not typically work on weekends required to work extra hours and on their days off to implement any key changes. The impact on local councils. Members within this group operate around the whole of Scotland in both rural and urban areas. The impact that local governments had through issuing their own guidance and measures for restrictions within their community had a significant effect on the management of individual care homes. Given that some of the members operated nationwide across Scotland, there were a variety of different national and local guidelines that they required to review and provide specific advice in each local area and to each care home to try to comply with the current measures being implemented. This had a direct impact on the capacity of already pressurised managers within each individual care home, as well as area managers for the whole of Scotland, who had a variety of diverse measures to address. The level of support afforded to care homes varied from one local authority to another. ICHS witnesses will be able to provide examples of both positive and negative experiences when reaching out and asking for help from their local council. Some are more hands-on than others, and we're conscious that the Chair, as noted in the preliminary hearing, would like to understand regional differences when considering impact, and that's something we're hoping to be able to assist with. The impact of regulatory bodies. Care home operators in Scotland are regulated by the Care Inspectorate. They regulate care homes for adult care providers. During the pandemic, care home managers were required to report to the Care Inspectorate as normal. In May 2020, the Scottish Health Minister raised her concern that private care homes were not following government guidance. As a result, the NHS Care Home Support Team was set up. NHS staff were redeployed to become infection control specialists, referred to as inspectors. These inspectors comprised nurses who were trained in other medical disciplines and completed a training course to become infection control specialists. The majority of the nurses had little prior experience in infection control, and this created tension between care home employees with many years of such experience and those inspectors. ICHS members have care home staff specifically trained in infection control as standard practice. That is so precisely because care homes are particularly susceptible to the spread of flu and viruses. Moreover, the impact on elderly residents of such infection is disproportionately serious when compared to the general population. Care home staff already understood the importance of controlling infections, limiting the spread and managing the risks. They had specific protocols in place to do so, and staff were trained on an ongoing basis. The advice of inspectors was often inconsistent with care home infection control policies or the advice given by other members of the care home support team. This created confusion, contradiction, and obstruction for ICHS members and their employees. Staff and residents were also impacted by the delay and disconnect between the public announcement of weekly testing for all care staff in Scotland, made in May 2020, and the actual delivery of this testing, which didn't happen until the end of June 2020. By that time, the first wave of the pandemic was receding. In a context of worry and anxiety about the pandemic, the public identification of the urgent need for such testing, raising that expectation for families, staff, and residents, required immediate action. Instead, the delay created concern that the necessary safeguards for all were not being implemented. Equipment. ICHS members will also speak to the difficulties they faced in procuring PPE and the stress and sometimes fear that this caused their staff. Guidance changed during the pandemic in relation to the types of PPE staff were required to wear. When this happened, demand dramatically increased, and it was often very challenging for private care home providers to locate and secure what they needed to protect their staff and residents. The principal purpose in the formation of ICHS, its participants in this process, is to ensure the integrity of the inquiry's investigation and to provide transparent evidence to assist the Chair in making his recommendations for the bereaved families involved. ICHS members had employees who were at the forefront of the health and social care sector, and the COVID-19 pandemic had a direct impact on their lives. Care home staff endeavoured to adhere to all measures and guidance, which was constantly changing, all while trying to provide the best possible care to their residents. Working in a care home during the pandemic has been described by staff members as being in the trenches. They weren't just carers for the residents. They tried to protect them from a deadly virus, and they held their hands when their family members could not. They witnessed firsthand unimaginable loss of life. Many staff members are still struggling to process what happened and how to ensure it never happens again. For staff and for families, that is what this inquiry must deliver. Thank you.
Indeed, Mr. McKie. Now, the next co-participant to speak is Long COVID Kids Scotland. Mr. Webster is back again. Good morning, Mr. Webster.
My Lord, the children of Scotland should be able to thrive and look forward to a positive future. Long COVID, the long-term illness caused by COVID-19, has blighted that prospect for too many. For too many, long COVID presents a seemingly insurmountable obstacle to an engaged, fulfilling and productive life. The inquiry is embarked upon its listening project, Let's Be Heard. In an adult world, the voice of children is too often ignored, disregarded, or belittled. I ask all of us in this room today to pause and think back. Did we hear the voice of children in the decision-making on masking, school mitigations, examinations, or immunisation? Or is our recollection that children were simply told how it was going to be? For reasons I find unfathomable, we have been precluded by the inquiry from allowing the voice of a child to be heard in these opening statements. Bearing in mind that we appear to have the technology to do so, and if we don't, that of itself must be a matter of concern. And bearing in mind also that the inquiry has already claimed the privilege as the masters of its own instance to play its video in its opening statements. And perhaps more vexing of all, that my learned friend Mr. Gale said yesterday that the inquiry in its Let's Be Heard outreach wanted to hear from children so adults are not speaking on their behalf. To be denied the opportunity to present our opening remarks in the manner we would wish risks the perception of a tin ear on the part of the inquiry as it takes its first steps. We can only hope this error of judgment, for frankly, that is what it is, will not be repeated. So it falls to me, my Lord, to read the word of a child. Many months ago, we all became ill with coronavirus, and very soon we became very ill. Some of us became seriously ill and had to stay in hospital. Our symptoms looked a bit different to the ones that grown-ups seemed to get, so our parents didn't always know what was wrong with us straight away. Coronavirus doesn't only affect children like us. Many of our parents got ill too. So we've had to stay at home and try to look after each other, but many of us got worse and needed extra help from doctors. Our parents were often scared. It seems like a long time ago that we felt well and could do some of the fun things we like to do. We're still at home and we're still unwell. Many of us are still in bed lots of the time. It can be boring, annoying, frustrating, and tiring, and we miss our friends. We miss feeling well. One day, a group of doctors and grown-ups who are ill just like us called our really long illness long COVID. Long COVID means that you're still ill after many months, and you never know how you feel when you wake up or try to play favourite games. One day you might feel okay, and the next you might feel terrible again. Sometimes you might feel okay and terrible on the same day. It's very confusing. Having long COVID is weird because it didn't exist last year. We're the first people to have lots of different things go wrong with us. The child goes on, "We didn't feel like this before we got coronavirus. We felt like you. Now we all have long COVID and nobody knows what to do. Our parents are working together to get us some help, and that's why we're telling you our story. We want to feel better again. And when we ask when we will feel better, nobody can tell us when that might be. It's making us sad." Well, a recitation of common symptoms, my lord, exhaustion, cognitive impairment and chronic pain for long COVID, truly fails to convey the true lived reality of this disabling and devastating illness. The inquiry has been offered, and we trust will hear from those with that lived experience of children and young persons housebound, bedbound and isolated, distraught, humiliated and suicidal, of professional scepticism, indifference and inaction in response, of the struggle to gain recognition, respect and action. Long COVID Kids is a grassroots organisation formed by individuals who have borne the burden of that lived experience and who have become disillusioned and frustrated by the slow, inadequate and frankly reprehensible response by government, national and local, to the long-term illness caused by COVID-19. They are the citizens who continue to suffer from the effects of the disease, who either are or are looked after those who are at greater risk of morbidity upon reinfection with COVID-19. There are over 250 families supported by long COVID Kids in Scotland, with a child suffering from long-term symptoms having contracted COVID. And there are believed to be around 10,000 children and adolescents suffering from long COVID in Scotland. They are entitled to answers to many questions, but above all, they're entitled to know whether their suffering and their sacrifices and their fate was avoidable. So for that purpose, amongst others, this inquiry must engage in a robust, probing and challenging and unrelenting critical analysis of what those entrusted with their care in government and our health service did and failed to do to recognise and act upon the risks of long COVID. This Scottish inquiry proceeds alongside that undertaken by Baroness Hallett. It's chosen to set its own course, one that is different from that taken by the UK inquiry, although the final destinations may not be too far apart. For reasons that are understandable, but not necessarily optimal, this inquiry has chosen to defer its consideration of decision-making until experiences and recollections have been recorded. However, when the time comes for analysis, the expectation must be that the inquiry will look at the peculiar nature of the Scottish response, that of the Scottish Government, Scottish local authorities, and Scottish health boards. The possibility of long-term post-viral illness was, as I said yesterday, well known before the pandemic. The question that has been asked of Baroness Hallett is that if long COVID was foreseeable, why was it not foreseen? In this inquiry, I ask, in addition, why was it not foreseen by our Scottish elected representatives and our Scottish health and education officials exercising their responsibilities for the care, well-being and education of the children and young people of Scotland? One of the recurring themes the inquiry will hear from those with a lived experience of long COVID is the struggle for recognition of the illness and recognition of the need for specific diagnostics, focused treatment and sympathetic support for those who continue to suffer, a professional scepticism that manifests itself in abject indifference to need. As we've heard, Baroness Hallett has already been referred to the then Prime Minister Boris Johnson's apparent scrawled response to the Department of Health and Social Care's call for recognition and support for people with long COVID. Bollocks. And to his apparent admission in his witness statement to the United Kingdom inquiry that he did not, at least initially, believe that long COVID truly existed. What we ask is for this inquiry to ascertain whether our First Minister, our Scottish Government, our health boards and local authorities were any better? Did they challenge? Did they gainsay? Did they follow the science? Or were they indifferent? Were they acquiescent? Were they supine in challenging such attitudes? Did they recognise the risks and consequences and the needs of individuals? And most importantly, did they act? And if they didn't, why not? Are they guilty of the same attitude to long COVID that found its expression in the crude terms that I've referred to? So as we embark upon our evidential hearings, I pose not a comprehensive list, but some questions in the light of the lived experience of many who question the adequacy of the preparation and the response to the pandemic. Standing a long-delayed recognition of long COVID and the struggle for recognition, was any planning undertaken by the Scottish Government, Scottish local authorities or NHS Scotland, with particular regard to the effect of a pandemic on the health, and as we'll consider later, education of the children of Scotland? If so, did it include consideration of the effects of long-term illness for children? If not, why not? Did the Scottish Government and others distinctly and proportionately weigh the effect of the pandemic on children and young persons in formulating its initial public health response to the pandemic? Again, if not, why not? Did the Scottish Government and others review, appraise and reappraise and revise its response in the light of the lived experience of long COVID in children and in the light of the emerging evidence of harm in research? If not, why not? Did decision-makers in the Scottish Government and NHS Scotland adequately warn the public of the risk of developing long COVID and take the disease into account in public health communications? Once again, if not, why not? And if they did, to what extent was that in response to patient advocacy rather than action initiated from a following of the science? Concerns as to long-term consequences of COVID-19 were appearing in social media in March of 2020. Public Health England's first published advice came in September 2020. Was there a distinctly Scottish approach? Those who have struggled against professional indifference and scepticism to highlight the issue of long COVID in children deserves, at the very least, an answer to these questions. For too many, their experience has been of little or no accessible designated paediatric diagnostic testing, treatment, or support for children and young persons suffering long COVID. So did NHS Scotland and individual health boards recognise and respond to the distinct needs of children and young persons with long COVID as knowledge expanded? And again, my mantra, if not, why not? Bearing in mind that the risk of long COVID remains for all of us, including the potentially crippling employment and economic consequences of personal disability, and that which might flow from having to care for a child with long COVID, did the Scottish Government and NHS Scotland ensure that in the light of what was known by the end of 2020, that long COVID will be the subject of appropriate data collection and modelling to enhance our knowledge of the disease and the methods of treatment of long-term sequelae? Our children, on whom the burden of responding to a future pandemic will fall, deserve assurance that the learning need has been acknowledged and acted upon. Scottish children with long COVID, that is to say those who continue to suffer, deserve to have some accountability if it is not. And beyond information gathering, did the Scottish Government and NHS Scotland ensure that in the light of what was known by the end of 2022, that NHS Scotland was adequately informed, funded and resourced to provide the specialist help and support that this cohort of sufferers continues to need? If not, why not? So as we embark upon the work of the inquiry, I again, as I did yesterday, exhort the Chair never to lose sight of a specific goal. This inquiry must conclude with pellucidly clear findings of fact as to how children and young persons' interests and rights as regard long-term illness were considered, weighed and acted upon, if at all, both in pre-pandemic planning and then in response to the pandemic. In his opening remarks, Counsel for the Scottish Government made reference to its 4 harms dashboard and to equality issues being included in the assessment made of each of the 4 harms. Well, we wait to see what that actually means in reality. It will, my Lord, only be with an understanding of what was considered and what was ignored, what was weighed and what was discounted, and what was done and what was not done, that lessons can be learnt for the future. So again, there needs to be rigour in ensuring the inquiry gives careful and discreet attention to this cohort of affected persons. We look forward to the inquiry producing background research directed to long COVID in children and young persons, in like manner as it has already produced background research papers for other areas. Again, there needs to be understanding of the practical consequences of long-term COVID-related illness and the steps taken to avoid and mitigate the same. And there needs to be an understanding that long COVID is an ongoing and escalating threat to Scotland's public health. It is debilitating, life-altering, and can be life-threatening. And so there needs to be accountability for failures, oversight, and indifference. The stated aim of the inquiry, and your Lordship's point of reference at all times, is to establish the facts of the strategic response to the pandemic in Scotland and to ensure that lessons are learnt from that response. Only on hard facts will the inquiry be in a position to ensure that those who have failed the children and young people of Scotland will learn lessons for the future. We should be able to look at the report of the inquiry and fairly conclude whether their suffering was avoidable. Although the inquiry is constrained by its terms of reference to consider matters other than planning over only the period of 2020 to 2022, it is in the area of long COVID that it is likely to have its greatest immediate impact. Long COVID is still prevalent. Children are still contracting it, and with every infection, a number will suffer the extreme effects of this awful and debilitating condition. The inquiry has the ability not only to reduce the impact of future pandemics, but also impact Scottish children now and in the immediate future. We need to ask ourselves, whose child, grandchild, nephew or niece might this inquiry save from the iniquities of this devastating illness? My Lord, I can't speak for all of the core participants in this inquiry. There are many able advocates in this room, and you will no doubt have the benefit of the best of their advocacy, as you will, I have no doubt, from the inquiry team. However, if I might venture, I suspect there is one common desire for many, if not all of us. This inquiry will hear evidence that at times will be harrowing. It will hear evidence that at times will be shocking. It may hear evidence that will frankly be scandalous. But through it all, there will be a desire for the truth to be established. The task ahead is daunting, and it will be long. My learned friend, Mr. Gale, in his opening statement yesterday, made an idiomatic reference to as you like it. May I, in similar vein, be so forward to venture a personal and hopefully enduring point of reference for your Lordship as he begins his task. It's a line from the Merchant of Venice. But at the length, truth will be out. My Lord.
Thank you very much indeed, Mr. Webster. All is Shakespeare, perhaps appropriate on St. Crispin's Day. Now, I think National Services Scotland, that's a mouthful. Ms. Doherty. Thank you.
Thank you, my Lord. I'm Una Doherty, and I appear today on behalf of NHS National Services Scotland, NHS NSS for short. NHS NSS welcomes this inquiry to establish the facts of and learn lessons from the strategic response to the COVID-19 pandemic in Scotland. The toll that the pandemic took was a significant one. NHS NSS extends its sympathy to the witnesses who will give evidence on the impacts of the pandemic. NHS NSS has arranged to be represented throughout the impacts hearing and will pay close attention to the evidence given. NHS NSS is conscious that although the inquiry team is aware of the organisation NHS NSS, the wider public watching and listening today may not know what it is or does, or why it is a core participant in this inquiry. This opening statement, therefore, contains a brief introduction to the organisation, explaining its roles and its interest in the inquiry. NHS NSS is a non-departmental public body accountable to the Scottish Ministers. It was created in 1974 to provide national strategic support services and expert advice to Scotland's NHS. Its headquarters are in Edinburgh, but it has staff based at a number of locations in Scotland. It consists of a number of different units providing a wide range of services. The services currently provided by it include those given by the following units: national procurement and logistics, practitioner and counter-fraud services, antimicrobial resistance and healthcare associated infections Scotland, central legal office, digital and security services, health facilities Scotland, national screening division, programme management service, Scottish National Blood Transfusion Service, and NHS Scotland Assure. Prior to 1st April 2020, NHS NSS also provided a service called Health Protection Scotland. Elements of that service moved from NHS NSS on 1st April 2020 to become part of a new organisation, Public Health Scotland. While within NHS NSS, Health Protection Scotland planned and delivered specialist national services aimed at protecting the people of Scotland from infectious and environmental harms. One part of Health Protection Scotland, prior to 1st April 2020, the antimicrobial resistance and healthcare associated infection team, remained in NHS NSS and is now known as Antimicrobial Resistance and Health Associated Infection Scotland. Although it is not primarily a public-facing organisation, services provided by NHS NSS have had a role in the pandemic response. Its roles during the pandemic response included the following: programme management services to a range of programmes, including the commissioning and decommissioning of the Louisa Jordan Hospital, Test and Protect, and the COVID-19 vaccination programmes. Leading the mobilisation of construction partners, including for the Louisa Jordan Hospital, and providing technical oversight on mechanical, electrical and water systems at the Louisa Jordan facility. Development of therapeutic convalescent plasma treatments, procurement and logistics of personal protective equipment, procurement, development and operation of digital platforms for Test and Protect and the COVID-19 vaccination and COVID-19 status certification programmes, including publicly accessible apps and web platforms, procurement and logistics for PCR testing, procurement and logistics for lateral flow devices and point-of-care testing, commissioning and operation of the National Contact Centre, providing support to Test and Protect COVID-19 vaccinations and COVID-19 status certification, operational delivery of the UK national and local testing programmes in Scotland, working with the UK Health Security Agency, local authorities, health boards and the Scottish Ambulance Service to ensure access to appropriate COVID-19 testing for the population, working with other bodies on the production of infection prevention and control guidance. NHS NSS looks forward to playing an active and useful part in the inquiry, my Lord. It will wish to learn from the issues that the inquiry examines. If there are recommendations made by the inquiry, NHS NSS may be involved in facilitating actions required by some recommendations. As a public body, NHS NSS understands the responsibility it owes to the inquiry and to the people of Scotland, and it will support the inquiry's work in any way it can. Thank you, my Lord.
Thank you very much indeed, Ms. Doherty. Now, We are again in the position as we were yesterday, this time even more extremely, that we've done all the participants, co-participants that were allocated to the morning session. It is a bit early to take lunch. I'm going to have to ask Mr. Pugh if he's ready to speak at the moment. I think actually to be sensible about this, I should put the burden on Mr. Bowie as well, because we can easily get both of you done before we take, even then, I think, an early lunch. Is that all right with both of you? Absolutely. Good, right, well, fine, thank you. I'm very grateful for your cooperation. Mr. Pugh first then, and you're for Public Health, beg your pardon, you're for the NHS Territorial Health Boards and Special Health Boards. Some terrible acronyms kicking about here. But
I don't think mine's even an acronym.
no, it's not, actually.
Yes, my Lord, I appear along with Cat McQueen, advocate on the instructions of the NHS Central Legal Office on behalf of the health boards, as they've been termed in their application for core participant status. My Lord, the health boards welcome this inquiry, which will allow a full exploration of the facts of the pandemic in Scotland as they relate to health and social care, including the response of the NHS. This opening statement will be the first time that the health boards, in the sense that they are collectively formed for this inquiry and the UK inquiry, have spoken publicly. So I'd like to explain some relevant background. My Lord, each of the health boards we represent is an independent NHS board in terms of the National Health Service Scotland Act 1978. They've grouped together for the conduct of both this and the UK inquiry due to a commonality of interests. 14 territorial health boards have responsibility for planning and commissioning services, including primary care, and for the delivery of frontline NHS services to local populations, together with providing secondary and tertiary care in Scotland's hospitals. The 5 special health boards provide care and support throughout Scotland, including ambulance provision, the National 24-hour helpline in the shape of NHS 24, the State Hospital, the National Waiting Times Centre, and the education of NHS staff. Each board is funded by and reports directly to the Scottish Government, although their management structures vary across the country. My Lord, the ethos behind the health board's participation in this inquiry is to strive for both learning and improvement. Through their participation and with that ethos to the fore, the health boards hope to benefit the future care of the Scottish people. The health boards are grateful to you, my Lord, for granting both core participant status and leave to appear at these impact hearings, and look forward to assisting the inquiry in its important work. The health boards anticipate active participation in the inquiry's work on the terms of reference relevant to health and social care. My Lord, following identification of the SARS-CoV-2 virus in early 2020, healthcare providers throughout the UK, indeed the world, strived to obtain knowledge of the virus, how it was transmitted, its effects on humans, and its effective treatment. The resulting COVID-19 pandemic has represented the biggest challenge ever to face the NHS in Scotland. On 17th March 2020, the Cabinet Secretary for Health and Sport acknowledged the scale of the challenge in a speech to the Scottish Parliament, where she said, "The scale of the challenge is, as the First Minister has said, quite simply without precedent. The response to COVID-19 requires a swift and radical change in the way our NHS does its work. It is nothing short of the most rapid reconfiguration of our health service in its 71-year history. That's why today, under sections 1 and 78 of the National Health Service Scotland Act, I'm formally placing our NHS on an emergency footing for at least the next 3 months." From March 2020, therefore, the health boards required to implement key changes in practice and policy to create additional capacity for COVID-19 patients and to manage infection, prevention and control within the existing NHS estate. They had to do so while continuing emergency, maternity, cancer services and urgent care, all of which have been maintained alongside many other services throughout the pandemic. Initial changes saw For example, non-urgent surgery, treatments and appointments suspended, together with some screening services paused. The increase in the number of intensive care beds from 173 to 585, with the result that NHS critical care capacity was not breached. Increase in the NHS workforce. For example, during the first wave in 2020, 4,880 student nurses were deployed. 575 junior doctors had their registrations accelerated, and recently retired staff were invited to return to work. And the adoption of digital solutions. For example, the number of video consultations increased from about 300 per week in March 2020 to more than 18,000 per week in November 2020. The initial changes also saw, of course, the implementation of a strategy set out in the Cabinet Secretary's speech on the 17th of March for reducing delayed discharges from hospital. The impact of that strategy, where it resulted in discharge to care homes, has presented one of the most fundamental questions regarding the health and social care response to the pandemic, which question this inquiry will doubtless explore in detail when considering term of reference G. As the pandemic began to take hold in Scotland, there was a rapid scaling up of testing capacity and contact tracing, together with the implementation of the Test and Protect strategy published by the Scottish Government in May 2020. By January 21, Scotland had the capacity to test 77,000 people per day, with 36% of that capacity coming from NHS Scotland laboratories. May 2020 also saw the introduction of a requirement for enhanced professional and clinical care oversight of care homes by senior health board staff, operating within multidisciplinary teams and alongside local authority officers, and that requirement has of course been referred to by a number of core participants already, my Lord. Later, the course of the pandemic saw the rapid development and scaling up of the vaccine programme. Once, on 8 December 2020, vaccines became available and were first administered in Scotland. The health boards delivered vaccines across a wide variety of locations to reach as many people as possible. By September 21, more than 7.9 million doses of vaccine had been administered in Scotland. Lord, none of these changes, nor others too numerous to mention here, would have been possible without the extreme hard work and dedication of the employees of the health boards. Exceptional effort and skill were shown not only by those employed in frontline services, infection prevention and control and health protection roles, but also by those who supported and enabled them, from porters and cleaners all the way through to administrative personnel. Healthcare staff and managers found new ways of working and of collaborating with colleagues and other agencies to ensure that, as a whole, the healthcare system has been able to withstand the pressures of COVID-19. The health boards wish to take this opportunity publicly to thank their employees. The extraordinary lengths to which NH staff went during the pandemic was, of course, also recognised by the public throughout. Who could forget clapping for carers every Thursday night? Of course, recognition of the hard work and dedication of those key workers comes with acknowledgement of the sacrifices they made. One need only recall stories of frontline staff being unable to return to loved ones at the end of their shifts for fear of infecting them, to understand the extent of such sacrifice. The emotional and physical toll upon those caring for people dying without their family and friends around them was huge, and the media images of those working in high-risk areas, dressed fully in PPE, caring for such seriously ill patients will live long in the collective memory. In that regard, the early pandemic saw difficulties in obtaining the correct PPE, even in high-risk areas, and this is again an issue that this inquiry will set out to investigate fully. While the impact of the pandemic has been felt by all, and while it will take time to recover, the deepest wounds are with those who have either lost loved ones or who continue to suffer physically and mentally due to the virus. The health boards wish, at this early stage, to express their deepest sympathies to those so affected. The health boards have not yet recovered from the impact of the pandemic and, on current estimates, are unlikely to do so for some time. The delayed impact on diagnosis of certain conditions, combined with the emotional and psychological toll of the pandemic and its knock-on effects on services is unlikely to be fully understood for some time. COVID-related conditions, such as long COVID, fall to be managed alongside the risk that new variants will again result in a surge of required hospital care. Moreover, I set out in the following paragraphs the way that the health boards will seek to assist this inquiry. I'm not going to read that out in detail. Suffice to say that at the moment, my Lord, the health board's commitment, both in these impact hearings and beyond, is to assist the inquiry in its important work. For present purposes, that means listening to the evidence of impact, which we will do with care. It is only by understanding of what worked well and what did not work well that the boards will be able to prove the health care for the Scottish people. Thank you again, Lord.
Thank you very much indeed. Now, Mr. Bowie, thank you.
Good afternoon, ladies and gentlemen. I represent Public Health Scotland, or PHS for short. In these brief opening remarks, we thought it would be helpful to make some comments about, first, who PHS is and what its role was in the pandemic. We're conscious that some of those watching and listening may not have heard of the organisation before now. And second, what PHS's purpose is in attending at these impact hearings today and in the coming weeks. Before I do that, at the outset, PHS wishes to express its gratitude to the inquiry for being granted leave to appear at these hearings, and of course, to recognise and acknowledge the incalculable loss and suffering that have been endured by the people of Scotland due to this awful pandemic. In our view, it is right, therefore, that the inquiry has decided to begin the evidence by hearing from people across Scotland about the impact the pandemic had and continues to have on their lives. Who then is PHS? What is its role? And what is its purpose at these hearings? Since 1st of April 2020, PHS has been Scotland's lead national agency for improving and protecting the health and well-being of the Scottish public. Central to its responsibility are the areas of health protection, health improvement, and health inequality in Scotland. It played a key role during the pandemic, particularly in the context of health and social care. It had a significant involvement in, for example, guidance, contact tracing, vaccines, and advising and supporting the Scottish Government in its public health messaging. Alongside this, and no less importantly, public health leaders within each of Scotland's 14 territorial health boards took many of the practical steps at local or community level to support the control of the pandemic. Unfortunately, since 2020, for most of us, terms like contact tracing have become part of common everyday speech. In attending these hearings, PHS will benefit from hearing firsthand the impact that such measures had on ordinary people. PHS is committed to listening and to learning the appropriate lessons, all with a view to doing better in the future. PHS will also do everything it can to assist the inquiry to fulfil its terms of reference. PHS is looking forward to playing a full role in the inquiry as it proceeds. As a national public body, PHS keenly understands the responsibility it owes, not just to the inquiry, but to all of the Scottish people, and it will do everything in its power to meet those responsibilities. Thank you.
Thank you very much indeed, Ms. Skye. Well, we're still only at 13 minutes past 12. It's Miss Domingo, I think, that appears on behalf of the Scottish Women's Rights Organisation. Are you able to speak now? Do you want to speak now?
I'll be close to 20 minutes.
Well, you're allowed to be 20 minutes, so you don't need to apologise for that. And I'm very grateful for you being prepared to be inconvenienced by being taken out of time. But thank you.
Thank you, my lord. My lord, I am Deidre Domingo, and these submissions are made on behalf of 5 Scottish charities: Close the Gap, Engender, Just Right Scotland, Rape Crisis Scotland, and Scottish Women's Aid. They are collectively described in this inquiry as the Scottish Women's Rights Organisations. The idea that COVID-19 was a great leveller that impacted everyone equally should be firmly dispelled. The most vulnerable, disadvantaged, and marginalised communities in society suffered disproportionate adverse outcomes, not only from the virus, but also from government policies implemented to manage the pandemic. Pre-existing discrimination and inequalities were exposed and exacerbated. The Scottish Women's Rights Organisations have been at the forefront of efforts to promote gender equality and to protect the rights of women, children, and young people, particularly those who experience domestic abuse. Individually and collectively, our clients are significant voices advocating for women's rights and equality in Scotland. Our clients welcome their designation as core participants in this inquiry. They have recently provided a joint written statement giving a broad overview of the key impacts of the pandemic on women in the context of this portfolio. 2 representatives of the Scottish Women's Rights Organisations will provide evidence to the inquiry next week to discuss these issues. Each organisation hopes in the coming months to provide the inquiry with a more detailed organisational statement that reflects on their unique experience during the pandemic and the experiences of the women and communities they support. While each organisation is separate, they share the view that the pandemic and the government's strategic response to it had an unequal and disproportionate impact on women, children, and young people, particularly those who experience domestic abuse and intersecting forms of discrimination and marginalisation. This opening statement addresses the key areas of impact on women under 4 broad headings. First, domestic violence and gender-based violence. The stay-at-home measures overlooked that for many people, home was not the safest place to be. One of the consequences of the imposition of lockdown and isolation rules was a rise in domestic abuse and violence. As explained by Scottish Women's Aid in their written submissions to the Equalities and Human Rights Committee of the Scottish Parliament, anxiety about coronavirus, frustrations related to quarantine, economic uncertainty due to loss of jobs, harmful consumption of alcohol, or other stresses do not cause domestic abuse. Domestic abuse is a pattern of behaviour that instills fear, and it is used by abusers to maintain control. Measures taken to address the pandemic, including lockdowns, early release of prisoners, closure of schools, working from home, reduction in the work of courts, and closure of some services and transition of others to remote provision, provide additional tools for abusers to exercise that control, and they remove the opportunities for women to seek help. It is recognised that men can be subject to domestic abuse. However, most abuse victims and survivors are women. Women experienced an intensification of domestic abuse during the pandemic, with increases in the frequency and severity of domestic abuse instances. Women and children were subject to heightened monitoring and control by abusive partners or family members. There was an increase in stalking and harassment from ex-partners, and an increase in abuse through online platforms and through manipulating child contact arrangements. For children and young people living with coercive control during the lockdown, the impact is yet to be fully understood. The places where they felt safest, schools, nurseries, sports or after-school clubs, or the homes of grandparents or other family members, were all taken away. The pandemic simultaneously increased the risks of harm to women and children and made access to safe spaces, vital services and support from family and friends much more difficult. Being at home all day meant that the time alone to speak freely to a support worker or to the police was dramatically limited. The pandemic also exacerbated pre-existing strains on services at a time when the funding environment over a period of many years had made service provision increasingly difficult. There was higher demand on support services, such as those provided by rape crisis centres, local women's aid services, and Just Right Scotland. And our clients experienced unprecedented contact volumes while operating with reduced capacity. Data from May 2020 showed that calls to Scotland's domestic abuse and forced marriage helpline were up 70% from the previous year. And there was an increase in web chat and email contact, with email numbers almost doubling. The pandemic created significant barriers to reporting sexual violence, which is an already vastly underreported crime. If sexual violence took place in circumstances that infringed prevailing lockdown restrictions, victims were even more reluctant to report their experiences. The suspension of court proceedings meant that the ability of victims and survivors to access the justice system was greatly reduced. There continues to be a large backlog of cases and significant delays. Rape Crisis Scotland has commented on the delays caused by COVID-19 as follows. From the outset, Rape Crisis Scotland raised significant concerns about the impact of the significant backlog caused by COVID-19 related court closures on the health and well-being of survivors of sexual crimes. This is supported by findings from the Scottish Centre for Crime and Justice Research, which evidences the significant and harmful toll that uncertainty and delays have had on the mental health of survivors. Access to legal services and representation was also impacted, as legal advice agencies had reduced or limited capacity, and many solicitors were no longer providing legal aid services due to funding issues. Women from Black and ethnic minority backgrounds and those who experience intersecting inequalities were particularly impacted. The no recourse to public funds condition is felt disproportionately by women, and it can increase vulnerability to other forms of exploitation, including trafficking and physical or sexual abuse. It can trap women in abusive relationships, particularly where they depend on the perpetrators of abuse and are unable to leave because of a lack of accessible options, including safe refuge spaces. This is compounded where women have uncertain immigration status. The second area is health impacts on housing. Increases in domestic abuse and gender-based violence have, in many cases, significant negative impacts on health, housing, education, and employment outcomes. In their written evidence to the Equalities and Human Rights Committee, Just Right Scotland stated that heightening mental health problems and exacerbating psychological distress are reported amongst already vulnerable and traumatised survivors of domestic violence. With reduced support services buckling under the increased demand, Women's Aid describe a perfect storm for these vulnerable women. Despite the NHS remaining open for those who needed urgent care, victims and survivors experienced difficulties in accessing crucial healthcare services during the pandemic. Lockdown increased the risk of homelessness and insecure or unsuitable housing for women, including for women seeking to leave abusive partners. There was an increase in women seeking crisis accommodation at a time when women's refuges were full. And because housing allocation processes were frozen, there was an inability to move women and children into permanent housing. For women subject to the no recourse to public funds condition, it was more difficult to access housing or refuge spaces. This increased their risk of destitution and homelessness and put them at higher risk of exploitation and harm. The long-term gendered nature of the health impacts of COVID-19 remain unknown. Evidence suggests that women are more likely to suffer from long COVID and to be admitted to hospital with complications of COVID-19. Women are experiencing significant mental health impacts from the pandemic and are almost twice as likely to report that their mental health worsened during the pandemic. The Mental Health Foundation links women's role as carers directly to increased levels of stress, anxiety, and isolation. Living in poverty and experiencing gender-based violence are also linked to long-term mental health impacts. Although women are more likely than men to seek out medical advice, this is not reflected in their health outcomes. The UK has one of the largest female health gaps in the G20. That is the difference in outcomes between men and women for the same conditions. The pandemic also presented specific gendered issues relating to healthcare, for example, in relation to perinatal and maternity care. Women received inconsistent and sometimes contradictory advice. Access to prenatal care varied depending on the local health authority's individual policies and rules. There is evidence about limitations on choice during childbirth. Women often had to attend medical appointments alone, and lockdown restrictions impacted access to maternity wards for partners. This led to anxiety and distress for women, and in some instances meant that they endured traumatic experiences, such as miscarriage alone. The third area is frontline workers and workforce participation. During the pandemic, about 80% of key workers in the health and social care sectors were women. As frontline workers, women put their lives on the line to deliver vital care to patients and care home residents throughout the pandemic. But they were undervalued, underpaid, and underprotected. The well-publicised shortages of adequate and effective personal protective equipment, PPE, disproportionately impacted women because there was a lack of PPE that was appropriately sized and fit tested to suit women's faces and bodies. And my Lord, as stated yesterday on behalf of the Royal College of Nursing, a loose-fitting surgical mask is unlikely to provide protection in the context of a virus that is airborne, and what was necessary were FFP3 masks, which require fit testing. The failure to keep frontline workers safe by providing sufficient supplies of suitable PPE meant that they were at increased risk of contracting COVID-19 in their workplace. And research indicates that healthcare workers were 6 times more likely to be infected with COVID. 10 years of underinvestment and cuts to public services meant that the health and social care workforces were understaffed at the start of the pandemic. This significantly impacted the health and well-being of frontline workers through burnout, anxiety and depression, and through exposure to unprecedented levels of death and grief. Not surprisingly, many health and social care workers are suffering from negative mental health consequences as a result. For social care workers, this was compounded by the comparative lack of recognition of the vital role they played during the pandemic, which alongside pre-existing poor paying conditions has contributed to low morale in the sector. In terms of financial equality and labour market participation, the pandemic exacerbated existing gender inequality in Scotland. In a report published by Close the Gap on the impact of COVID-19 on women's labour market equality, it was reported that women's disproportionate responsibility for care and other domestic labour affects their ability to enter and progress equally in the labour market. Women are 4 times more likely to give up employment because of multiple caring responsibilities and are more likely to be in low-paid, part-time employment than male carers. The closure of schools and nurseries during the pandemic meant that women bore the brunt of unpaid childcare, homeschooling supervision, and housework, which led to increased stress particularly if juggled alongside paid work, and particularly for single mothers. Women, particularly those who experience intersecting inequalities, are more likely to face poverty and financial dependency as a consequence of the pandemic. Women were more likely to work in shut-down sectors, such as hospitality or retail. They were more likely to be furloughed and for longer, and they were more likely to have lost their job or had their hours reduced. This was especially the case for women from Black and ethnic minority backgrounds, disabled women, younger women, and low-paid women. Finally, a lack of intersectional gender competence in decision-making. The Scottish women's rights organisations submit that many of the unequal impacts of the pandemic on women were foreseeable. And while there were aspects of the Scottish Government response that were welcomed, there were also failures by the Scottish Government to sufficiently consider the impact that the pandemic and lockdown measures would have on women and children. It is vital that emergency response measures and decision-making recognise the overlapping drivers of vulnerability or disadvantage that contribute to women's overall experiences. That is, taking into account race, ethnicity, disability, age, location, sexual orientation, socioeconomic group, and migrant status. One of our clients' key concerns is the accumulating impact that the increased risk of harm has on women and children in Scotland. It is the position of the Scottish women's rights organisations that at all levels of decision-making during the COVID-19 pandemic, there was a failure to apply an intersectional, gender-competent approach to the decisions being made, a lack of gender-sensitive, sex-disaggregated data on which to make decisions, and a failure to comply with the legal requirements of the Scottish-specific duties of the public sector equality duty. By mainstreaming equality and undertaking equality impact assessments in decision-making. The lack of gender competence and the failure to recognise the differences between men's and women's lives had an impact on policy and decision-making across all services: health, justice, employment, welfare, education, children and families, and housing and homelessness. These failures invariably delivered unintended negative consequences for women, particularly those who are already marginalised. I'm going to make a brief comment on the inquiry's work and expert evidence. For our clients, it is critical that the voices and experiences of women, particularly those who are at risk, are reflected in the inquiry proceedings and taken into account when assessing the Scottish Government's strategic response and the broader impacts of the pandemic. The Scottish women's rights organisations encourage the inquiry to recognise that issues relating to gender and equality permeate all aspects of the impact of the COVID-19 pandemic. They are not standalone topics to be considered in isolation, but rather they are systemic and should be central to all aspects of the Scottish inquiry's proceedings. Our clients are aware that the inquiry has recently published a policy statement on taking a trauma-informed and human rights-based approach to its work, and that a separate statement on equalities will be delivered and published in due course. We welcome this intention, and we will consider these documents carefully. Our clients submit that it is vital that the inquiry takes a gendered approach and an intersectional focus on equalities, which can only be achieved by ensuring that the inquiry has appropriate gender competence. The Scottish women's rights organisations encourage the inquiry to seek input from an expert or experts in gender competence and intersectionality to help inform its work and processes and to meet its stated commitment to equalities. Our clients have made proposals in respect of expert evidence in our written submissions. It's not necessary to repeat these, but we invite the inquiry to consider the suggestions made. To conclude, my Lord, there were many consequences of COVID-19, and the Scottish women's rights organisations recognise the grief and loss experienced by so many bereaved families across the country, and the impact on those who continue to experience effects from contracting COVID. For women, children and young people in Scotland, the pandemic has increased vulnerability and domestic abuse, and there has been a recognised rollback on women's equality and rights. In a parliamentary briefing on the Coronavirus Scotland Bill, Engender stated, "When the safety nets put in place by the state are stretched to breaking point, it is women that are hit the hardest." And this health crisis is highlighting gaps in UK social and economic policy in an unprecedented way. Without conscious effort, resources, and focus from government and policymakers, the gendered impact of the pandemic and the consequent harms to women's health and well-being risks being a lasting legacy of COVID-19. Thank you, my Lord.
Thank you very much, Ms. Domingo. Very good. It's almost 25 to 1 now. We were pleased to Ms. Doherty will not ask you to speak now. Can I ask you please to be back at 25 to 2?